Hi, everyone. Our group is doing our presentation on exercise and physical activity. I'm Claire Kabinski.
I'm Sydney.
I'm Kim.
I'm Sam.
And I'm John.
So just for introduction, we honestly didn't find a whole lot of similarities between all of our studies and PICO questions, but we did find that there are multiple changes that can be implemented into PT practice that can improve individualized impairments. And we focused on type 2 diabetes, low back pain, lower extremity stress fractures, limited hip range of motion, and osteoarthritis specifically in the knee and the hip. So my PO question was, is a subischal prosthetic socket design as effective at lowering back pain as strength-based therapeutic interventions for patients with lower extremity amputations? So if you look at the picture I have in the slide, so the slide on the left, A, is the ischial containment, and B is subischial containment, which was what the focus was on. Ischial containment was more common, and as of right now, they're using subischial containment more often. And then I do have a excerpt from what a subischial containment is, and it's just a socket that's meant to improve static and dynamic spine to pelvis alignment in efforts to reduce low back pain. So the study I looked at was entitled A Comprehensive Treatment Strategy for Chronic Low Back Pain in Patients with Bilateral Transfemoral Amputations, Integrating Changes in a Prosthetic Socket Design. It was actually not very good evidence-wise. It was a case study, so that's a 3B level of evidence, but it was the only study I could find. So the subject was a 27-year-old US Navy member who was injured in an improvised explosion in 2013, which ended up being a bilateral transfemoral amputee, and he was 125 pounds and 72 inches tall. So the findings that happened was that his physical therapy was reduced from 2.5 times a month to 1.5 times a month, the focus remaining on his low back pain. The O3 disability index changed from 26% to 10%, meaning he was more functional independently. The patient's self-reported low back pain changed from 10 to 4 on a pain scale. This was not the pain scale we learned that was 6 to 22. It was actually a 0 to 10 pain scale. His functional index improved from 22.8 to 5%. 22.8 means he was at moderate disability. 5 means he was at minimal disability. His bothersome pain from 20.8 to 70.9. His daily activity pain 22.5 to 3.1, and his mobility disability to 26.1 to 12.5. So strength for this, all data collected was statistically significant. His pelvic alignment did show an improvement. It was actually a 9.5 decrease in anterior pelvic tilt, which even though that was kind of the whole point of this, they only mentioned that very briefly. They more were focused on his own pain reduction and disability reduction. The weakness, of course, with the sample size, it was only him. Strengthening PT was included, so this was not actually an isolated variable. It was 2 parts, and then it was only April to August. He was looked at when it was started and several months later, and then he has not been looked at for any long-term results. And then this was just a small thing from the study I wanted to show you. So this was him throughout the study. A was when he was in the ischial containment, B was subischial in April, C was subischial in June, and D was subischial in August. So you can just see the change in his pelvic tilt as he continued wearing the subischial socket.
So my PICO question is, what is the effect on hip range of motion when college students take a break from sitting every 30 minutes versus every 2 hours? And the article I used for this was prolonged sitting and physical inactivity are associated with limited hip extension, a cross-sectional study. And since this is a cross-sectional study, this is a level 4 of evidence, which is not very strong. But the study was published in February of 2021, and the author stated it was the first study looking at the effects of sitting on hip range of motion. So the study investigated the effects of sitting time as well as physical activity on passive hip extension. There were 144 participants between the ages of 18 and 65. Participants were excluded from the study if they had a BMI over 30, they were pregnant, they had a pre-existing lower extremity musculoskeletal condition, or any other condition that prevented them from lying supine. And after all these exclusion criteria were taken into place, there were 98 participants, 49 were male and 49 were female. So participants were then given a survey that asked them to record their physical activity as well as their sitting time each day for a typical 7-day week. And to try to make the sitting times more accurate, the researchers broke up the day into morning, working day, and evening. So everyone was then divided into groups based on their activity level and sitting levels. So low activity was considered less than 150 minutes of exercise per week. Prolonged sitting was considered more than 7 hours per day. So there was a low activity prolonged sitting group, high activity minimal sitting group, a high activity and prolonged sitting group. So after this, the Thomas test was used to measure passive hip extension, and the measures was taken using a digital goniometer. And then after that, the researchers applied a downward force to ensure that the range of motion wasn't being limited by a bone. And the researchers who were taking these goniometer measurements were blinded to the survey results. So it was found that the low activity prolonged sitting group had 3.7 degrees less hip extension than the high activity prolonged sitting group, which didn't reach statistical significance. And then the high activity minimal sitting group had 2.4 degrees more hip extension than the high activity prolonged sitting group. This means that that also didn't reach statistical significance, but the high activity minimal sitting group had 6.1 more degrees of hip extension than the low activity prolonged sitting group, which did reach statistical significance. So some strengths for the article was that it had a good exclusion criteria to make sure that there weren't any extraneous factors affecting the hip range of motion, that it was more of the sitting, and also that the researchers were blinded to the group the participants were in. This was especially important since they were using a goniometer to measure the hip extension. So this will prevent the researchers from accidentally using or changing the angle that they found. And they also ensured that the hip extension wasn't limited by bone, because if it was limited by bone, sitting would have no effect on this range of motion. And then the last strength was the questions about the sitting time were broken up into the morning, working day, and evening, because estimating how much you're sitting in a day can be really difficult. People would probably exaggerate one way or another. So this hopefully made the results a little more accurate. But then for weaknesses, it was a small sample size. The sitting and activity data were gathered by a survey, which isn't great at all. It would have been better if they could have wore some sort of device to measure this. And using a goniometer to measure range of motion isn't a perfect way to do it. There will be inter-user error and stuff. But since this was the first study ever conducted on the effects of sitting on hip range of motion, it can be a good launching pad for future studies. And it didn't really answer my PICO question, but it was the first study, so it's not very surprising.
Okay, so my PICO question was, would taking a daily vitamin D supplement help prevent lower extremity stress fractures in young athletes? So the study I found was named Association of Serum Vitamin D Levels and Stress Fractures in Collegiate Athletes. It was a cohort study level 2B. The subjects were 802 NCAA Division I athletes, 497 men and 305 women. The athletes needed to be on a sports team for at least one semester from 2012 to 2018 to be included in the study. Athletes were excluded if they had a previous stress fracture diagnosis. Each athlete completed a medical screening, which included blood work to get a baseline of vitamin D levels. Those below 40 nanograms per milliliter were given a supplement. Those below 20 were given 50,000 IUs weekly for 8 weeks. And those between 20 to 39 were given 30,000 IUs weekly for 8 weeks. And then it was documented during the 8 weeks if they experienced a stress fracture, and a radiograph or MRI scan was taken to confirm the diagnosis. And then after the 8 weeks, the athlete's vitamin D levels were checked again. So some findings were that after reassessing each athlete's vitamin D serum levels at the end of the 8-week period, it was found that the rate of stress fracture was 12% higher for those who remained low in vitamin D compared to those who were low at baseline but improved past 40 nanograms per milliliter. It was also found that for both male and female athletes, baseline vitamin D levels were higher for those who played an outdoor sport versus those who played an indoor sport, presenting evidence that athletes who participate in indoor sports are at a greater risk for vitamin D deficiency. So overall, yes, taking a daily vitamin D supplement would help to prevent lower extremity stress fractures in young athletes. Some strengths were that the study included a relatively large sample size to obtain data from. The vitamin D serum levels are a measurable form of data. And then the study also included a variety of sports for both men and women. And then some weaknesses were that it was limited to athletes from a single university. So some things such as like geography or the intensity of each training program could also play a role in the rate of stress fracture. And then lastly, the researchers had put a lot of faith in the athletes and assumed that they were being honest in reporting a stress fracture, and also in consistently taking their prescribed daily supplement if necessary.
So my PICO question was, does resistance strength training when compared to aerobic training offer increased health benefits in regards to overall better management of glycemic control in individuals with type 2 diabetes? So the article that I found was effects of aerobic training, resistance training, or both on glycemic control in type 2 diabetes. And the type of study was a randomized control study, so it was a level 1A. The participants consisted of 251 previously inactive adults that were ages 39 to 70 and diagnosed with type 2 diabetes. The participants were required to have an HbA1c value between 6.6 and 9.9% to be included. And an HbA1c value is the average blood glucose levels over the past 2 to 3 months. And the normal or healthy range was considered to be between 4 and 5.6%. So for the summary, there were 4 groups that were formed. There was an aerobic group, a resistance group, a combined aerobic and resistance training group, as well as a control sedentary group. So for the aerobic group, they exercised on treadmills or bicycle ergometers where the heart rate monitors were used to achieve target heart rate. They started with 15 to 20 minutes per session at 60% of their max heart rate at the beginning of the study, but progressed to 45 minutes at 75% of their max heart rate by the end of the study. The resistance training group performed 7 different exercises on different weight machines. They began with 2 sets of each exercise with a weight that allowed them to perform 7 to 9 reps maximum. And then they progressed to performing 3 sets with that same criteria by the end of the study. And then the combined exercise group did the full aerobic and resistance training programs. And these exercise groups were performed 3 times a week for 22 weeks with a 4-week run-in phase. And that run-in phase was just to ensure that participants would cooperate. And then all of the different groups were recommended a diet that was not intended to cause weight loss. And even the control group was recommended this. And then some of the findings that they found were that aerobic and strength training alone showed improvements in HbA1c levels. But overall, it was found that the combined resistance and aerobic group provided the largest benefits regarding glycemic control. So some of the strengths of the study is that it was a fairly large sample size. It was 26 weeks long with a 4-week run-in phase. There were 4 different groups, even a control group. There was personal trainer supervision for each of the exercise groups, and they were all recommended a diet to minimize dietary variability. And then some of the weaknesses of the study is just that there was a combined exercise group that participated in the full duration of both of the exercise programs. So it's hard to say if the combined exercise group improved because of that combined exercise or if it was just because they completed a longer amount of exercise each week. And then it's difficult to compare these two types of training because aerobic uses large muscle groups without breaks, and then resistance strength training focuses on certain muscle groups, and then they get breaks between sets.
All right, so my PICO question was, does physical activity in the adult population who participate in normal exercise, which consists of like repetitive body movements, lead to higher or lower risk of developing osteoarthritis in the knee and hip compared to those who previously participated in a recreational or competitive sport? And so to answer this question, I had to do two studies to just kind of give you both sides. So this one is the influence of physical activity related to joint and stress and the risk of the self-reported hip and knee osteoarthritis, a new method to qualify for physical activity. So this is a longitudinal study, and there was 5,284 participants that they used for the study. And the criteria was that you just had to be like over 20 years old. And so this looked at the association between hip and knee osteoarthritis and training frequency, like pace and total weekly mileage. And participants were followed up for a median of 12.8 years. So there wasn't a lot of like structure to this study. It was kind of just a lot of people went on with their lives and they looked at it. They all did this in a like recreational activity. They weren't doing it at a high level or participating or in any type of like team sports or anything like that. And then the findings were that anything pretty much like walking, running, jogging, biking, cycling, racket sports, stretching, exercise, weight training, nothing increased the risk of hip and knee OA, no matter what type of volume, intensity, time, or frequency was used. So this was pretty fascinating to me that they found that it was better for people. So, I mean, all the stigma of getting up and going and exercising is obviously true, and this was proven right here. So some strengths of this were that the long follow-up, which allowed for the measuring of all the various different risk factors for OA, and then it also captured a wide range of activity levels ranging from sedentary to like more vigorous activity. And then the weakness is that like most of these people were like white collar educated Caucasian, like healthy like people. And then also mostly the participants did not have any like heavy physical labor jobs. So like there was no way of being able to see if someone who had a more stressful like physical activity required job would lead to that risk of OA. And so this study focused a lot more on like the high level athletes. So this is knee OA in former runners, soccer players, weightlifters, and shooters. So again, this is a longitudinal study, and it was 117 males from the ages 45 to 68 were used. And all these males previously participated in the like Olympic Games or in the European Championships for soccer. So there was long distance runners, soccer players, weightlifters, and shooters, about 28 to 31 of each of those. And what they did is they used 2-hour like interviews for these participants, and they had like special emphasis on like the sport, exercise, and leisure time, as well as like their occupational knee loading and injuries to the knee. As you can imagine, I mean, training at this high level for some odd years, from being 20 years old all the way up to you're 40 or something like that, could be very stressful. And so what the findings were is that the mean length of training was at least 3 times per week, and it ranked from about 10 to like 14 and a half years, which is crazy, putting that much on your body for that long. But some statistical significances were found for soccer players who developed tibiofemoral OA and weightlifters who developed patellofemoral OA. And this was very crazy to me. So the normal joint space with your tibia and your femur is usually 1.7 millimeters. And with some of these athletes, it was seen to like get all the way down to 0.6 millimeters. which is very small, and it just shows how much wear and tear was put on those spaces to shrink down to that much. And then also they developed some varus deformities. So usually you have standard valgus of 2.4 degrees, and one of them was as bad as all the way up to 13 degrees of varus. And then soccer players also experience meniscal and ligamentous knee injuries during training as well, which kind of goes along with the shrinking of the spaces and stuff like that. So some strengths with this is that it had like the long follow-up, because they followed them over this long period of time of them participating in like the games and championships. And then they use like professional athletes, which I guess could go both ways, because it's a more rare population, but then again, it's a more rare population to be able to do a study on. So I thought that was very interesting. And some weaknesses is that it was just males. And then all these athletes had like different lifestyles, like after they participated at the high levels as well. And that wasn't really talked about either. Like if they like started working a job for whatever case scenario, like they didn't mention that at all. So I use that as a weakness. So in summary, we concluded that changes in prosthetic socket fit can change pelvis tilt and in turn help relieve low back pain. Increased sitting time may reduce passive hip extension, and physical activity may counteract the effects of sitting. Taking a daily supplement D vitamin has been shown to prevent lower extremity stress fractures in active individuals and athletes. Combined aerobic and strength resistance training is most effective way to improve glycemic control for individuals with type 2 diabetes. And someone who participates in exercise has a lower risk of developing OA compared to someone who competes and trains at a recreational and professional level.
So lastly, we just have some questions for you guys. So some of these are, what exercise have you utilized in MS or wellness clinic this semester that are considered aerobic and or strength training exercises that you would implement into your practice to benefit patients with type 2 diabetes? Would you be willing to suggest a change in prosthetic hip socket before implementing manual PT to deal with low back pain? And lastly, what are some practical ways we could reduce the loss of hip range of motion from sitting?
Thank you for listening to our presentation.